Good morning to all of you. It is my great pleasure to introduce Dr. Giovanna Chidini from the Pediatric Intensive Care Unit of the Ospedale Maggiore in Milan, Italy. Today we have to discuss a very interesting paper that was very recently published in the Journal of Anesthesia, Analgesia and Critical Care, the official journal of SIARTI, the Italian Society of Anesthesia, Resuscitation and Intensive Care Medicine. This paper is entitled Implementation of Non-Invasive Neuro-Adjust Ventilatory Assist in Pediatric Acute Respiratory Failure, a controlled before-after quality improvement study. And this study deals with a crucial aspect in pediatric intensive care medicine, the way to improve, to optimize the administration of non-invasive ventilation. As we will discuss later on, two techniques for non-invasive ventilation, NAVA, NIV, and pressure support ventilation, NIV, have been compared. And this is a very important study because it is not based on differences on patient-ventilator interaction, but on real clinical endpoints. Please, Giovanna, would you briefly present your study and the main topics of your study?
Okay, thanks, Giorgio. Thanks to you to have invited me here to share the conclusion of our paper. And the topic is the pediatric acute respiratory failure and the treatment with non-invasive ventilation. Because recent studies show that children treated with non-invasive support at in early phases of acute respiratory failure may have a great benefit in reducing the complication linked to mechanical ventilation and endotracheal intubation. However, in the pediatric age, the optimization of patient-ventilator interaction is very difficult due to the respiratory mechanics characteristic of children. That is a very high respiratory rate, very weak capability of trigger the ventilator machine, and very short neural inspiratory and expiratory time. So that several papers report a high failure rate during non-invasive pediatric ventilation and a high intubation rate, up to 45–50% of children treated with non-invasive ventilation. So the aim was our study was to compare a population of children treated with early NAVA ventilation in the early phase of respiratory failure compared to a population admitted in the 2 years before the implementation period and treated with conventional flow-triggered non-invasive ventilation. And the primary endpoint of the study was a clinical endpoint, not a physiological endpoint, that is the intubation rate between groups. Then we considered other secondary endpoints, such as PICU length of stay, hospital length of stay, the difference in number of needed invasive devices, such as a central venous catheter or arterial catheters, the difference in morbidity, such as nosocomial infection, for example, bloodstream infection or ventilator-acquired pneumonia. In this period, we planned the study as a before-after study. So we are able to draw data from our clinical data chart, electronic data chart, and we included 35 children admitted for respiratory failure and early treated with non-invasive NAVA, compared with a cohort of patients admitted for acute respiratory failure and treated with a conventional flow-trigger pressure support. The population, the cohort were similar about age, weight, severity of respiratory failure. For example, PEF ratio was similar in the two groups, around 104 in both groups. No difference were reported between PaCO2, pH, or respiratory rate, and causes of admission. So we had children admitted mainly for viral infection. And looking at the main result and the main endpoint, we were able to found that intubation rate was reduced, significantly reduced in children treated early with NAVA. That is the probability to be intubated in the first 4 hours from admission was less than children treated with a conventional flow trigger. If we look at the secondary endpoints, that is the PICU length of stay, hospital length of stay, and days on ventilation, we were able to define that children treated with NAVA were ventilated for less days compared to children with pressure support. They had a shorter PICU and hospital length of stay. So if we look to the physiological parameters, for example, PF ratio, PSO2, respiratory rate or heart rate, we found that NAVA resulted in an earlier improvement in all physiological parameters compared to pressure support. And this data was significantly maintained over all physiological parameters. We had no complication due to technological failure of devices. For example, for pressure support, flow cycled or NAVA ventilation were well working. We had no problems with technological failure, nor major events during ventilation. If we look at the intubation rate, we are impressed about this difference, but nowadays we are not able to be sure that this data will be confirmed in a prospective physiological randomized study on a more extended population.
Thank you, Giovanna. It's extremely interesting because it's the first time we discuss about clinical results, not asynchronous and things like this. So it's something really, of course, as you told, it needs to be confirmed by a prospective, large prospective randomized study, but it's extremely interesting. However, as every study, it has also some limitation, particularly related to the design. Would you shortly comment on that?
Yes, I agree completely with you, but we decided to carry on the study after we published with our group a physiological crossover study that affirmed that asynchronous were really reduced with NAVA. So the second question was the clinical efficacy of these methods. Is really more useful for little children compared to more conventional ventilation. And the question arises because NAVA technology is an expensive technology, both due to the equipment. That the equipment is particular, and we need a learning curve to use properly these methods. So we need to be convinced that there is an effective advantage over other technologies. And the study design is for sure is not the optimal study design, and because we conducted a single center study, and we are not able to compensate for biases that were able to develop along the entire study period. However, on the other side, in our unit, we are a strict protocol to manage children with respiratory failure. That is, for example, sedation, position of patients, nutrition, medical treatment are not varying in the last 2 years in which we enroll the patients.
Okay. Thank you, Giovanna. what impressed me was also the zero mortality rate in both groups of patients. That is a quality, as a could we say, it's a good quality of treatment sign. Thank you very much, Dr. Chidini. It was a real pleasure to discuss this paper. Thank you.
Thank you, Giorgio. Thank you all, and ad maiora.
Ad maiora.